let's talk about all the places where you could technically like bleed to death. So one is going to be to the ground. Okay, so you lacerate your radial artery and you lose all of your blood volume to the floor. Okay. Next is going to be into your chest. Okay, so you suspect a chest trauma, absent breath sounds, you place a chest tube, and immediately 2 liters come out of the chest. That is an indication, a hard indication to move towards a thoracotomy. Okay, over 1.5 liters or over 200 an hour. For different texts say different things, but again, if there's a high output from the chest tube, you should probably be in the OR exploring the chest. Okay, next is going to be the abdomen. You can bleed to death into your abdomen. And then to do this, we would do an exploratory laparotomy. All right. The next one that people don't think about too much is the pelvis and or the retroperitoneum. So I did a little talk on the retroperitoneum recently, but the pelvis as well. So if you have a bad pelvic fracture, it tends to cause bleeding from the blood vessels that supply the pelvis from the internal iliac artery. And these patients do really well if we can get them to IR for angioembolization. But you can bleed to death into your pelvis, your abdomen, your chest, onto the floor. Okay. The thigh can hold a lot of blood as well, but typically you're not going to bleed to death from that. These are going to be the major body cavities in which there's a problem. So the reason in our secondary survey we get a chest x-ray, we get a pelvis x-ray, and we get a FAST exam, it's in order for us to figure out where the bleeding's coming from. So if you have a hemodynamically unstable patient, I need to determine where you are bleeding from. Are you bleeding into your abdomen? Are you bleeding into your pelvis? Or are you bleeding into your chest? So that's what we're thinking the whole time. Or do I need hemorrhage control here with like a tourniquet? Okay, so those are the anatomic areas that we're looking for blood loss.